Inglese. I'm a clinical senior lecturer and rheumatologist at Queen Mary University of London, but also a clinical immunologist by training. And it is very nice to see that there are many people attending this session on immunodeficiencies, which you can understand. For me, obviously, I'm biased. I find it a very important and interesting topic, but I do think it's an interesting topic for the whole rheumatology community because of a twofold relevance. One is the secondary immunodeficiencies that we tend to cause with our treatments, but also because primary immunodeficiencies, they do represent models where we can understand quite a lot about the conditions that we treat. And today, we have 4 amazing speakers who will give us an overview of different aspects of immunodeficiencies. So without any further ado, I will leave the floor to my co-chair to introduce the first speaker.
Thank you very much. Also from my side, a very warm welcome to this really interesting session. And it's an honor for me to introduce to you our first speaker, Professor Frédéric Riou-Lucas from the INSERM in Paris. And he's a really well-known expert in the theme he will talk about, decoding primary immunodeficiency, what every rheumatologist should know. He described first mutations in FAS, in ALPS patients, and later on, very important for us, also mutations in STING1, vasculopathies, and overlap to autoimmune diseases. And in the end, also great work on interferonopathies in corona patients. So it's your talk now, and I'm really looking forward to it. Thank you.
Thank you very much for the introduction. So I'm working in Paris at the Imagine Institute, which is an institute dedicated to genetic diseases, and within these diseases there are immunological diseases. And so here are the people working in my team, which is a mix of researchers, clinicians, and young clinicians that are doing PhDs, and more senior ones like Bénédicte Neven, Brigitte Bader-Meunier, Pierre Cartier, and Alain Fischer, who is still around and very helpful in the progress of his project. So I have no conflict of interest. So what all rheumatologists should know in 20 minutes, it's an ambitious objective. So I will give you an overview and some examples, like a glimpse of PID. So primary immune deficiencies and dysregulation. So it's genetic diseases that are related to any type of immune cells, T cells, B cells, could be neutrophils as well, caused by monogenic mutations in these immune-related genes. Sometimes it's also called inborn errors of immunity, REI, but I would discourage to use this, and I will tell you why. So PIDs is usually seen as a susceptibility to severe infections by common pathogens. But in fact, the patients with PIDs, they also develop cancers, mostly hematological cancers, and also autoimmunity, inflammation, and allergy. So this is, in fact, summarizing the main function of the immune system's clearance of pathogens, very well known for a long time, tumor surveillance, tissue repair, and self-control. It's very important for the immune system to control itself, to avoid autoimmune manifestation or autoinflammation. So there are monogenic mutations, and there are more than 500 genes that have been described so far that can lead to primary immune deficiencies and dysregulation. Should we talk about PID or IEI? Inborn errors of immunity. There are more and more examples of somatic mutations affecting these immune-related genes, so they are not necessarily inborn. And we have the example of the VEXAS, that I think is a good example to say that it's not an inborn error of immunity. Secondly, we have a very important man in France who was Robert Debré, who was the man who organized the university hospital centers, so to put the clinicians, the patients, together with the university and the research. So that he has a gigantic view, and he organized the research in France for decades. So he has a saying that was, "Our children are our eternity." And I would add that they are not our errors. Patients are not errors, and I think we should avoid to call them inborn error of immunity, and I would privilege primary immune dysregulation and deficiencies or primary immune disorders. So there is an evolution of the concepts and the treatments in the last years. First of all, thanks to the NGS, you could see the numbers of genes that have been identified in the last 15 years, going from hundreds to more than 500. The concept, first, it was thought that there were a general population of bugs that can infect patients with PIDs, but finally it was seen that there could be very narrow type of infections, that these patients may develop hyperinflammations and autoimmune and immune dysregulation. A very important concept is that one gene can lead to many phenotypes, and many genes can be also associated with one phenotype, so I will try to give you some examples. And then we move from the pathophysiology to study the autoimmune mechanisms, and we realize that PIDs may also reflect defects of extra hematopoietic tissues. And regarding the treatments, I will go just shortly to say that we moved also from cellular therapy to molecular therapy and precision medicine. That is really the goal in the last years to treat these patients. So at Necker Hospital, we have a register of more than, so now it's approaching 8,000 PID cases, and you can make some, so it's a good number, it's not a tremendous number, but it's a good number. And we can make some analysis of the presentation of autoimmune manifestation in patients with PID as compared to the general population. And as you can see, autoimmune cytopenia and mostly autoimmune hemolytic anemia is one of the highest risk to be developed by patients with PID. So a child coming with autoimmune hemolytic anemia, you should think about monogenic diseases, and you should look for gene mutations. But it's also true for rheumatologic disorders, and especially the rheumatoid arthritis of pediatric age. You can see that the relative risk as compared to the general population is 40, showing that, again, if you see a child coming to the hospital with rheumatologic disorders, you should think about PIDs. So autoimmunity can be a presenting features and not only infections. So you can have patients coming only with autoimmune or inflammatory manifestations without any type of infections. That can be a presenting feature of PIDs, and it's a rationale to search monogenic predisposition in autoimmune diseases. So that's what we did in the last years. And we started to, so that was a kind of a prism. We started with patients with early onset autoimmune manifestations in order to see whether we could find monogenic causes. And we started with Evans syndrome, so that is autoimmunity against the platelets and the red cells. And that was the work of Jérôme Adjadj when he was a PhD. And we found that in 2/3 of the patients, we could find mutations in immune-related genes. And some of these mutations were already known to cause primary immune disorders. So these mutations were mostly heterozygous mutations with partial clinical penetrance, which means that we may have carriers that are healthy. And we found mutations in many genes, immune checkpoints, CTLA4, the JAK-STAT pathway, which is really central in the control of immune response, apoptosis, fast ligand, FAD, NF-kappa pathway, mTOR, and more recently, actinopathies. So I will not go, of course, through the detail of these type of mutations, and I will give you some examples to show that in some situations, you should think about primary immune deficiencies and dysregulation. So it's also important for the adult patients. So we did this work with Jérôme Adjadj on the pediatric onset of Evans syndrome, but with Etienne Crix, we recently did the same work. So that is really basic sequencing patients that have adult onset Evans syndrome, and we found mutations in 10% of the cases. So showing that even in adults, you can have immune-related gene mutation that is associated with the onset of the disease. And we will see at the end that it's very important to determine that, because then you can propose targeted therapies to the patients. So I would like first to start with an example for rheumatologists, I would say. So these patients with this early onset severe erosive polyarthritis that was not responding to many lines of treatment. This patient was from a consanguineous family, and he had a brother who had Evans syndrome, very severe Evans syndrome, and unfortunately he died from intracerebral hemorrhage due to these very low counts of platelets that was resistant to treatment. So we went on for genetic analysis of this family, and then we found mutations in a gene that is called LRBA. So the two brothers were homozygous, the two parents were heterozygous, so it was autosomal recessive mutations, and we could see that that was leading to the complete absence of this protein LRBA. What is LRBA? LRBA is a protein that is involved in the intracellular traffic of many proteins and in these vesicles. And on the top here, you have CTLA4, that is an immune checkpoint that is negatively regulating the T-cell activation. CTLA4 goes to the intracellular compartments to go to the lysosomal destruction unless it meets LRBA in these endosomes, and that recycles CTLA4 to the membrane. So therefore, when you have no LRBA, you have no longer the recycling of CTLA4, and then you have a reduced expression of CTLA4, and therefore you have the lack of a break of the immune system. So CTLA4 is expressed constitutively on regulatory T cells, but also on activated conventional T cells, and LRBA deficiencies and CTLA4 haploinsufficiency, when you have one allele, that is mutated on the CTLA4 gene, that goes to the same phenotype. There are genetic phencopies with low CTLA4 expression on activated T cells and Tregs, and that leads to severe early onset autoimmunity that can be very broad types, broad spectrum of autoimmune manifestation, autoimmune cytopenia, but also lymphocytic tissue infiltrations and organ-specific autoimmune diseases. So here is the spectrum of the manifestations of patients with LRBA and or CTLA4 deficiencies. And as you can see, there are a lot of autoimmune manifestations. Arthritis is not the most prominent presentation in these patients, but still there are some patients. So if you see a patient with early onset arthritis, one of the genes that can be affected is the regulatory gene of the immune response, that is CTLA4 or LRBA. So why is CTLA4 important? So when you have the activation of the T cells, it needs the antigen through the T cell receptor and then the co-receptor CD28. And after activation, there is expression of CTLA4 that is very similar to CD28 and that can compete with the interaction with the CD80 and CD86 on the dendritic cells, and that blocks the activation of the T cells. On the regulatory T cells, CTLA4 is constitutively expressed, and therefore that is one of the mechanisms by which these regulatory cells are blocking the immune response or controlling the immune response. And very interestingly, there are molecules on the market called abatacept, which is the fusion of CTLA4 with FC IgG1, CTLA4 Ig. And then if you provide these molecules to the patients with CTLA4 deficiency or LRBA deficiency, then you cope with the exact consequences of the genetic defect, and then you can compensate the defect. So does it work in vivo? So you see these patients that had many lines of treatment. Since we realized that it was a CTLA4-related pathophysiology, then there was the rationale to give him targeted treatment, and therefore abatacept, and that controlled the disease progression. Of course, it cannot come back, but that was controlling. And that is working in any type of presentation of symptoms related to CTLA4 or LRBA deficiencies. So like lymphoproliferation, you may have patients, you may have patients with a huge spleen, and after 8 months of abatacept, you can see that the spleen is shrinking. And then you have lymphocytic tissue infiltrations, like patients with GLILs, and they have infiltration in their lung. And after treatment by abatacept, you have a clear improvement of the patient. And here's an example of intracerebral glioma that was treated by abatacept, and that was reduced profoundly by the treatment. So when you identify the gene, then you can understand the mechanisms, and therefore you can act exactly on that mechanisms and not on other type of mechanisms or a broad immune suppression. So abatacept is efficient for most LRBA CTLA-4 deficiencies related manifestations. There are maybe some, it's maybe less efficient in patients that have autoimmune enteropathy or digestive tract related symptoms. So now I would like to move to early onset lupus, and that is the work that we made with Alexandre Bello in Lyon and Maud Tussaud. So again, very basically, we took 200 patients with early onset lupus, and we made exome sequencing. So we had some findings that were quite expected. So complement deficiency, that is known since more than 50 years to be associated with the onset of lupus. We had nucleic acid sensing deficiencies leading to interferonopathies, and it is known that the lupus disease is related to an excess of interferon production. And as we can see here, most, if not all, the patients had increased interferon production or interferon signatures, showing that there is a dysregulation in the interferon production and signaling. Then we had mutations in genes that are known to be associated with SPEED, IRAK4, and these mutations are usually associated with severe infections, but that was found in these lupus patients. And unexpectedly, we had mutations in genes that are not related to immune defects, but since they were really damaging, very rare mutations, we reported them. We don't know the pathophysiological mechanisms and the association with these mutations, but they are there, and there was no other mutation so far that could explain, that could be found in this analysis. But maybe we have to move to the genome sequencing to see that maybe there are more common genes related to lupus. And then we had partial deficiencies in regulators of the JAK-STAT pathway, so SOX1 mutations and PTPN2 mutations that we have reported with Alexandre Bello's team separately, and that were coming from this cohort of patients, so they are also susceptibility genes for lupus. So, SOX1, we found these mutations in different types of presentations. Autoimmune cytopenia in this first family, lymphoproliferation in this second one, and then in patients with lupus, and in this family with the same mutations with the patients with renal lupus and severe psoriasis. So that was really puzzling to find this very different presentation in the same family. So is it related to the same gene? So SOX1, as I said, is a regulator of the cytokine response. So the JAK-STAT pathway is very important to signal the cytokine, the cytokine stimulation, phosphorylation, then it goes to the nucleus and it makes this transcriptional factor function with a lot of immune genes that are expressed, and in particular the SOX, and the SOX are in fact blocking the activation. So that is really a negative loop of regulation mediated by the SOX. And therefore, we can intuitively understand that if we have less SOX, we have more response to the JAK-STAT pathway, and then the immune system is no longer controlled. And there are therapeutics that were already on the market and used in patients, so that are the JAK inhibitors. So these were shown to be efficient in vitro, and then I will go quickly in vitro to show the efficacy in these patients with quite severe dermatologic presentation and alopecia, and after 6 months of treatment, she had a very good improvement. And very interestingly, the psoriasis patient had 2 different JAK inhibitors with a complete response with the second JAK inhibitors, showing that you can treat psoriasis and lupus, because that is the same family, with the same mutation, with the same drug, because it is the same mechanism, because it is the same cause. So if you identify the genetic cause and you identify the mechanisms, you may treat very different diseases with the same molecule. And then going further, we looked in by the ESID registry and the UK Biobank to the presentation of patients with SOX1 mutations. You can see that the rheumatologic manifestations were 1/3 of the patients. We do not see much in our cohort because we are recruiting patients with autoimmune manifestation, mostly autoimmune cytopenia and lupus. So the association of a gene with a disease is related to your bias of inclusion of patients. So one gene, one disease, it's a past notion of the 20th century. In fact, mutation in one gene can be associated with a broad spectrum of clinical phenotypes, from no symptoms, that we call the incomplete penetrance, to autoimmune or autoinflammatory disease of variable severity. So when we look in Evans syndrome, autoimmune cytopenia, and lupus, we could find mutations in genes that are associated with specifically with the autoimmune cytopenia, some other specifically with lupus, but a lot of genes were common between the two types of diseases. And very quickly, in the last minute, how we can explain this incomplete penetrance. We described, 40 years ago, fast mutations, dominant fast mutations, germline mutations in these kind of pedigrees. So it's a defect of apoptosis, lymphocytes are hyperproliferating, and these patients are developing autoimmune cytopenia. And then we describe somatic cases. In sporadic cases, we could see, and there is a specific population in these patients, that is CD4 negative, CD8 negative T cells, and in these cells we could find somatic mutations occurring in the progenitors. And then we found that in this type of incomplete penetrance, the patients had the germline mutations in the family together with a second mutation of the second allele, or uniparental disomy, so loss of heterozygosity, explaining the onset of the disease in the patients and not in the healthy carrier of the heterozygous mutation. And that is the scheme to show that in some cases you have these somatic mutations appearing in progenitors, and that provides a selective advantage, and therefore these cells are able to move to the periphery and then to trigger the disease. So, in conclusion, early onset autoimmune diseases or familial autoimmune disease, but also sometimes adult autoimmune diseases, there is monogenic predisposition, but non-Mendelian expression. You may have the mutations in several individuals. Some are affected, some others are not affected, and sometimes with very different symptoms. There are the role of modifiers, somatic mutations, maybe monoallelic expression, digenic inheritance, and so on, and environmental causes. So if you see in this family, we have different autoimmune diseases. Is it monogenic? We have in fact the gene that is segregating in the family, and together with somatic mutation, you can explain that these patients are developing autoimmune manifestation and not these ones. And that is important because you can go to targeted therapies. So the take lab message, because you don't need to take message at home. You have autoinflammatory disease and autoimmune disease can be associated with monogenic predisposition, even in adults, even if present in healthy relatives, in relatives with very dissimilar diseases, early onset of familial immune-related manifestation, it's an indication for genetic analysis. Then you have to go further when you have mutations with unknown significance. You have to go for immune functions, vaccinal response, proliferation assay, phenotype, and so on, to see and to orientate the conclusions, and therefore the identification of a monogenic cause can offer target therapies options. I would like to thank all the collaborators, and Alexandre Bello in particular, and Stefan L., our main collaborators, and that work is made at the Institut d'Imagine, and I thank you for your attention. And sorry for moving this.
Thank you very much for this really wonderful talk. Are there any questions? So perhaps just a short question from my side. When we mainly treat adult patients, so starting with early onset of the disease, when we take the patient's history, this is of importance, and also the family medical history. So because it needs to be always very easy for us, not the difficult steps, just the very easy first steps when we are in contact with our patient.
No, I understand. I mean, if it's sporadic cases of autoimmune manifestation without familial history or without the past history of the patient with some notions that are not necessarily autoimmune manifestation but recurrent infections, inflammation, then you can go with the familial history of the patient's history to genetic disease. Sporadic cases of onset at 40 years of age of a lupus in a woman, I'm not sure I would go for genetic analysis.
And with respect to the mutations in the JAK-STAT pathways you described, is it already possible for you to predict the best treatment options? So whether the JAK inhibitor should be highly selective for example, JAK1, or less selective like TOFA for pan-JAK?
It's a very good point, because it's a very complex pathway, because you have interactions between the JAKs, interactions between the STATs, and in particular you have a transphosphorylation of JAK1 to JAK2. So if you use JAK2 specific inhibitors, you may not block the JAK1 hyperactivation, and we are trying to work on in silico models to predict what could be the best according to the mutation that is ongoing.
Yeah. Thank you so much.
Thank you very much.
So we move on to now secondary immunodeficiencies. And it is a pleasure to introduce the second speaker, Nathalie Freder from the Department of Rheumatology and Clinical Immunology in Freiburg in Germany. And they host a Center for Chronic Immunodeficiency in Freiburg. So I understand they have an extensive case series of patients with immunodeficiency. So we look forward to this presentation, please.
Thanks for the invitation and also the kind introduction. So I will talk about secondary immunodeficiencies in rheumatic diseases, and I will mainly focus on three main questions, which is who's at risk, what should I measure, and when should I prevent, treat, or replace immunoglobulins. So what is secondary immunodeficiency? While primary immunodeficiency is defined as an intrinsic disorder of the immune system, secondary immunodeficiency is defined as either a transient or permanent impairment of the immune system caused by extrinsic factors that are not inherent to the immune system itself. Causes of secondary immunodeficiency, or SID, are manifold. Worldwide, the most common causes are actually malnutrition and infections, here on this side, but in the Western world, actually medications and chronic diseases are the most common causes, and here is also where we find our rheumatic patients with immunosuppressants and autoimmune disease. And mechanisms of SID in rheumatology can basically attribute it to four different types. The first is disease-intrinsic immune dysfunction, then drug-induced immune dysfunction, then organ or barrier damage, and then comorbidity and aging. Regarding disease-intrinsic immune dysfunction for rheumatic diseases, this has been especially described in lupus with hypocomplementemia and then neutropenia or lymphopenia, in RA especially with Felty's neutropenia, which can go hand in hand with LGL expansion, then in AAV with neutrophil dysfunction and hypogamma, which can actually sometimes precede therapy, and then in Sjögren's disease, where mucosal barrier failure is actually the most common cause, but also lymphopenia may play a role. Regarding treatment-specific SID, this, of course, is complex. I tried to group this into three groups. The first is antibody failure, which is the mechanism of B-cell depletion with rituximab, which leads to hypogammaglobulinemia, which then predisposes the patient to infections with encapsulated bacteria, especially of the respiratory tract, and pro-vaccination responses. Then the second big group is cellular or opportunistic infection risk. To this, I would count glucocorticoids, cyclophosphamide, mycophenolate, azathioprine, and also the JAK inhibitors. And this may predispose the patient to bacterial, viral, fungal infections, and also opportunistic infections such as pneumocystis. And then the third big group is pathogen-specific risk. And towards this, I would count the TNF inhibitors, which impair granuloma formation, which predisposes the patient to DP and fungal infections, but also complement inhibitors, which, if you inhibit the terminal complement pathway, will predispose patients to meningococcal infection. The prototype of drug-induced SID is rituximab, where repeated B-cell depletion impairs the generation of new antibody responses, so the plasma blast and plasma cell actually are not affected in the beginning. but you have problems of generating more antibody responses. The reported rates of hypogamma in rheumatology actually vary widely, with 10 to 56% of patients described, and this is due to different IgG cutoffs being used, then different diseases being studied, and different pre-treatment exposure. But it has become clear that AAV patients are especially vulnerable, with cohorts showing up to 45% of patients developing hypogammaglobulinemia. So secondary hypogammaglobulinemia is actually the best characterized SID, is approximately 30 times more likely to occur than primary antibody deficiency, but may be reversible, and as said, frequently occurs after B-cell directed therapy. Most studies so far have focused on rituximab. The American Association of Allergy and Immunology has proposed some definitions for standardization, which is very important actually also for future studies. And they propose to define hypogammaglobulinemia as an IgG below 7 grams per liter, and then to further stratify by severity with an IgG between 4 and 7 as mild hypogammaglobulinemia, and then below 4 as severe and below 2 as very severe. You have an increased risk of secondary hypogammaglobulinemia if you have a low baseline immunoglobulin, if a patient is of older age, in cyclophosphamide treatment with cumulative rituximab exposure, with glucocorticoids, with renal disease, and then in AAV and severe systemic disease, especially lupus with renal involvement. Other types of secondary immunodeficiency apart from antibody deficiency is actually poorly defined so far. But there's 3 main groups. One is cellular or T-cell impairment, which predisposes to viral, fungal, or opportunistic infections. Then innate or neutrophil impairment, which can occur in neutropenia, in severe inflammation, or also with IL-6 directed therapies, which predisposes the patient to bacterial or fungal infections. And then barrier or organ damage, which can happen in ILD, in bronchiectasis, in patients with renal disease, and then also with skin ulcers, which mainly predispose the patient to recurrent site-specific infections. So risk factors for secondary immunodeficiency can be classified as either patient-related risk factors. Here, important factors are the age, above 60 years, and then chronic comorbidities, especially chronic kidney disease, diabetes, COPD, and malignancies. Of course, then also splenectomy is a very important factor, and malnutrition may also count towards it. Disease and therapy-related factors is AAV, and as said, lupus, especially with nephritis, hypocomplementemia. Then if the patient already has lymphopenia or hypogammaglobulinemia at baseline, and then if you use multi-agent immunosuppression, glucocorticoids above 10 milligrams per day, cyclophosphamide, and again the cumulative rituximab cycles. Infection patterns that should count as a warning sign and that you should investigate are if the patient has more than 4 infections requiring antibiotic treatment per year, if the patient has had more than 2 pneumonias in his life, or more than 2 severe cases of sinusitis per year, if the patient has had repeated hospitalizations due to infection, if there have been atypical pathogens such as pneumocystis or aspergillus, or also if there's unusual sites of infection. So what should we do then? The first step is always to take a good history of infection risk, where you should ask the patient for severe infections, which should be pneumonia and sepsis, or also opportunistic infections, then hospitalizations, antibiotic courses per year, and then also bronchiectasis is an important factor. Then you should do basic lab workup, which should include the full blood count with differential count to receive lymphocyte counts, then the immunoglobulins and complement. And then to rule out protein loss, you should do serum protein and urinalysis. And then if lymphoma is possible, you should consider serum electrophoresis or immunofixation. And then also an HIV test should be included in workup of immunodeficiency. Further workup should include lymphocyte subsets and then specific antibody responses, where we normally use pneumococcal and then tetanus and diphtheria. Also in a patient who has recurrent bronchitis or pneumonia, you should do a chest CT to look for bronchiectasis. And then further workup is actually advanced, so normally you probably have to refer the patient to an immunologist. So monitoring IgG levels is actually recommended now in the guidelines of AAV, RA, and SLE. And here it is especially important to measure IgG before every rituximab cycle and then to recheck IgG levels 4 to 6 months after each cycle. Also important point is that you should actually never act on one single low IgG value but confirm with a repeat. And my special piece of advice would be that if you can, you should always do a differential blood count and immunoglobulins before starting immunosuppression in actually every patient, because this will help you find the patients who are at risk. So what can we do as rheumatologists? The first step is to reduce modifiable risk, where we can check whether we can optimize therapy, we can minimize glucocorticoids, we can try to avoid combination therapy, and we can reassess rituximab interval and dose. Also, patient education plays a big role, where smoking cessation is important, and then personal protective equipment, hand hygiene, and these points. The second point is to monitor, check regularly, check immunoglobulins again after 3 to 6 months, and periodically thereafter track the lymphocyte counts, and do ask the patient to maintain an infection diary to know how many infections occur. Then the third step is to prevent, check the vaccination plan of the patient, and then evaluate whether you should use pneumocystis prophylaxis or also antiviral prophylaxis, or whether the patient might actually benefit from antibiotic prophylaxis. This we will see in the next slides. And then in patients who have confirmed antibody failure and ongoing significant infections, you can consider immunoglobulin replacement. So regarding vaccinations, it's especially important to vaccinate against respiratory pathogens, where pneumococcal vaccination, influenza, RSV, if that is possible in your country, COVID, and then pertussis is important. And then Shingrix vaccine should always be used in immunosuppressed patients. And generally it is to say that non-live vaccines can be given safely to all patients, where you should consider a treatment pause of 1 or 2 weeks before vaccination if possible. However, live vaccines should be avoided during relevant immunosuppression or should be discussed with a specialist beforehand. And also an important point is to ensure vaccination protection of immunocompetent household members, which will also protect the patient. This is actually the only slide I included on opportunistic infection, who should get cotrimoxazole prophylaxis. There's a strong indication in patients who receive prednisolone above a dose of 20 milligrams, especially if you have a second immunosuppressant combined with that. In AAV, in induction therapy, every patient who receives cyclophosphamide, and then in anti-MDA5 positive dermatomyositis due to their strong risk of severe ILD. You should also consider cotrimoxazole prophylaxis in patients with lymphopenia if they have less than 200 CD4 T cells. If you have rituximab combined with glucocorticoids above 30 milligrams, in patients who have ILD or other structural lung disease. And then if you have a combination of age above 65, chronic kidney disease, or COPD or diabetes. The best tolerated regimen is 960 milligrams 3 times per week, but instead you can also use 480 milligrams daily. In case of sulfur allergy, that depends on your country. You can either use dapsone, atorvaquone, or pentamidine. Then another point, actually, if the patient has more than 4 infections needing antibiotics per year, you can consider general infection prophylaxis with antibiotics, especially if the patient has recurrent respiratory tract infections. Common regimens that we use is azithromycin, 250 milligrams 3 times per week, or cotrimoxazole, 960 milligrams, but once daily. So this is a higher dose than pneumocystis prophylaxis. However, it is to say that evidence in secondary immunodeficiency is limited, and regimens are mainly extrapolated from PID, from COPD and cystic fibrosis. And also it is to say that this is off-label, of course. Anyhow, this actually helps a lot of patients. And then for immunoglobulin replacement, this you can consider in patients who actually have severe infections despite antimicrobial treatment. and who either have to have an IgG level below 4 grams per liter or documented specific antibody failure, which usually is pneumococcal antibody failure. You can either use intravenous or subcutaneous immunoglobulin, and you should always try to reach a target IgG level of higher than 7 grams per liter, so in the normal range. Here it is important to assess reversibility. So as I was saying, this can be reversible in secondary immunodeficiency, and this should be checked regularly. Also, I want to say that the evidence base remains limited in rheumatology and actually in all secondary immunodeficiency. Yeah. Then I included one slide again. So this is actually an important point. We heard about primary immunodeficiencies, but about 30% of primary immunodeficiencies first manifest in adulthood. So actually, SID can also be an unmasked PID. And you should think of PID in case of infections that were already present before start of immunosuppressive therapy. If you have opportunistic or unusually severe infections out of proportion to immunosuppression, if you have the positive family history, as we heard earlier, then if you have multiple autoimmune diseases or lymphoproliferation in one patient, or also if you have persistent immunological abnormalities such as pro-vaccination response in addition to T-cell defects or in addition to low switch memory B cells. And in this case, you should always consider genetic testing or referral to immunology. One more point I wanted to make is that there's actually a huge evidence gap in SID in rheumatology. We still don't know the true prevalence of SID in rheumatology and also actually generally of SID, especially SID beyond rituximab and hypogammaglobulinemia are poorly characterized so far and are also difficult to measure, of course. Then also the IgG replacement threshold is unclear so far in rheumatology. There have been few studies. And also interventional evidence is so far completely lacking. Due to low evidence, there's also no dedicated EULAR or ESID guidelines so far. So this is a point to work on. So this takes me to my take-home algorithm. So in any patient with recurrent or severe infection that we see in clinic, we should ask the patient to count infections. Then we should measure immunity, where really I would advise you to do differential blood count and immunoglobulins before starting immunosuppressive therapy, ideally in every patient. Then look for amplifiers, see whether you can prevent with vaccines, antibiotic prophylaxis, maybe modify therapy, or then refer the patient to the immunologist or replace immunoglobulins. With that, I would like to thank the audience, and I'm open for questions.
Thank you very much for a very clear, comprehensive overview. So we have time for a couple of questions, and I want to remind everyone that there is a possibility also, if you have a burning question during the presentation, to ask it in the chat, but obviously it is a small room, so I invite you to come to the microphone. So yes, please.
Thank you for the great presentation. I would like to ask what is your perspective about low-dose glucocorticoid, since it's a very debated still subject among rheumatologists?
No, actually, there have been studies, and I also believe that also low-dose glucocorticoids of 5 milligrams can affect the immune system. So actually, in case of recurrent infections, I would always try to reduce glucocorticoid dose further or try to stop glucocorticoids.
Okay.
From the audience?
In a patient with GCA, over 60 years, no other diseases, smoking, 50, 70 milligrams corticosteroids a day. Would you give PGP prophylaxis or not?
Yes, we in Freiburg do on a regular basis, and we had also some patients who had pneumocystis infection, which can be quite severe and which actually can lead to death of the patient. So we actually use prophylaxis in these patients. And then also we had studied hypogammaglobulinemia, so that can also be quite severe in the first year. So prophylaxis is, I think, if that is allowed in your country, a good thing to do.
Yes, please.
Excellent presentation. In the primary deficiency of the complement, is there any drug that you avoid, any specific drug?
You mean if you already have primary immunodeficiency of complement? Yeah. No, not really, yeah, but then you need to discuss, obviously, whether you should put the patient on antibiotic prophylaxis. But yeah, there's no, yeah. So basically, for the people who don't know, primary hypocomplementemia or mutations in the complement pathway may lead to lupus. No, we don't have any special therapy that we would advise the patient to take, but yeah, do consider antibiotic prophylaxis.
And I think we're running out of time, but I wanted to ask a very brief question practically on how to capture these events. Now, particularly, I do think that we're going to see an increase of secondary immunodeficiencies with the new B-cell targeted therapies. Exactly. And as you said, we also don't know the depth of immunodeficiency we will see. So I know there are a number of registries in various countries, and also European for primary. They should also capture the secondary immunodeficiencies. But in your experience, do they really do it, or do we need to think of something to better capture at European level these events? Or there is already an infrastructure.
I think we should make an effort to capture this better and to characterize better. And the first point is that basically we should standardize some kind of definitions, where really I would suggest for hypogammaglobulinemia to use 7 grams per liter, which, yeah, some other institutions use different cutoffs. But yeah, it would be a good effort actually to come together and have a registry for secondary immunodeficiency.
There's probably room for considering a task force for EULAR or something. Okay, I'm afraid we need to move on.
Thanks.
Thank you very much. Thanks.
Thank you. So then it's a pleasure for me to now introduce Professor Fabio Candotti. He's head of the Clinic for Immunology and Allergy at the University Hospital Lausanne, and he's the current president of the European Society for Immunodeficiency, ACID. It's a pleasure to have you here.
Thank you very much for the introduction, and thank you to the organizer for inviting me to spend some time with you talking about the overlap between immunodeficiency, primary immunodeficiencies, and autoimmunity. Some of the notions here have already been touched on by Frederick, so hopefully there will be some reinforcement of the concept that he already showed us. I'm going to, I don't have any conflict of interest to disclose. I'm going to start with the case of this delightful 71-year-old patient that I met in the clinic that told us about his early history of episode of immune thrombocytopenia at the age of 5 years. Then he remembered a few respiratory tract infections, otitis media, and in his adolescence or around the early adulthood, he experienced recurrent episodes of skin vasculitis. His ITP became a chronic problem, and at 39 years of age, he was splenectomized to take care of their conditions. And since then, he had a pretty regular life, eventless life. So this is a case where we don't have a lot of details to really be able to offer a diagnosis. I don't know if anyone in the audience would like to venture one. I wouldn't. For us, it was actually an easy diagnosis because we saw these patients 2 weeks after we had made a diagnosis in his grandchild or a grandson of Wiskott-Aldrich syndrome. I remind you briefly what that disorder is. It's an X-linked primary immune deficiency characterized by thrombocytopenia, eczema, and increased susceptibility to infections, malignancy, and autoimmunity. This is typically a pediatric disease. It is diagnosed early in life. But there is a percentage of people that are not severe enough to present early, and they are diagnosed in adulthood. So it's not really a mistake for our colleagues that followed our 71-year-old patients to not having identified his diagnosis. But it is a little disappointment in the sense that early cytopenia, early thrombocytopenia, infections, and a vasculitis issue should bring to mind the idea of an immunodeficiency complicated by autoimmunity. And this is because this concept has been around for decades. And just to give you an idea, in 1974, in a paper that in those days were able to summarize the whole field of primary immunodeficiency in one table with 15 conditions, Fred Rosen, that is one of the grandfathers of the field working in the Children's Hospital of Boston, had identified, was telling us in the text that the common variable immunodeficiency presents with an unusually high incidence of autoimmune disease. So this story, this notion that we should be looking for immune deficiencies in patients that present with autoimmunity is certainly not something that is a new concept. So how frequent is autoimmunity in primary immunodeficiency? Well, what we can do is to look at the ACID registry of patients. And if you look at what are the presentation, the clinical presentation in the patients that are collected in the registry, not surprisingly, most patients present clinically with an infection, but at least 1/4 of them presents as a presenting feature, clinical feature, a episode of immune dysregulation. More interesting is that the fact that if you look at what are the concomitant presentations of patients that have an immune dysregulation, there are at least around 3,000 patients that present only with immune dysregulation when the diagnosis of immune deficiency is made. So that's certainly an important point to consider and to realize and remind ourselves that immune dysregulation can be determined by monogenic disorders, like Frederick told us. I think you know that the primary immunodeficiencies are organized, categorized in 10 different categories, where now we have arrived at more or less 600 different entities. What is important to notice also is that at least 100 of these entities present typically with immune dysregulations and therefore autoimmunity, autoinflammations, or lymphoproliferation. Frederick already told you there are different molecular causes for these different immunological pathways that are affected that end up causing autoimmunity in these patients. In general, you would find that they are caused by abnormal lymphocyte development that affect the ability of the mechanism of central and peripheral tolerance. There are dysfunctions of peripheral T and B cells tolerance caused by increase of co-stimulation. So the CTLA-4 story is one of those, by overactivation of the JAK-STAT pathway, overproduction, dysregulated production of interferon, and reduction in apoptosis. And the third general concept, mechanism that are affected by these monogenic disorders are the effective clearance of apoptotic debris, immune complexes, and those are the complications of several innate immunodeficiencies. So there are at least 100 different monogenetic immunodeficiencies that present with autoimmunity. What kind of immune manifestations are you expecting to see? The typical systemic autoimmune complications, autoimmune cytopenias, lupus, Sjogren's, and sarcoidosis. You can find all of those, but also a whole series of organ-specific autoimmune diseases that are listed there, and you know them better than me. And it's safe to say that there is no autoimmune complication, no autoimmune disease that cannot be associated to a primary immunodeficient disorder. If we look at the frequency of specific autoimmune manifestations within the primary immunodeficiency diseases, again, with studying data from the ASID registry, you can see that not unexpectedly, most people that have a primary deficiency, autoimmune disorders, also have severe infections, lymphoproliferation, hypogammaglobulinemia, but the autoimmune-mediated cytopenias or organ-specific autoimmunity of the gut, of the skin, of the eye, are very frequently seen in these patients. So you can expect to see those, or you can think when you see those that an underlying monogenic immunodeficiency can be present. So why or when should you suspect the primary immune disorders? As it was mentioned already, when the autoimmunity presents early in age, and when it presents with a severity that is surprising in a patient of that age. Certainly, if there is more than one autoimmune conditions, cytopenias, endocrinopathies, or lupus, that certainly is a red flag for you to go a little further and consider monogenic causes for those complications. We have seen a clear association of infection episode followed by the onset of autoimmunity. So if you happen to notice that association, definitely is another flag to consider. If you're lucky and in your history it comes up that there is a family history of infection, autoimmunity, autoinflammation, that also certainly facilitates and should tickle your suspicion. And please do a small immunological workup, because with simple analysis of the CBC, of the levels of immunoglobulins, a complement, and perhaps with a simple immunophenotype, you can find the defect of immunity, immunological results that can direct you to a primary immune disorder. Why should we try to find the monogenic cause of immunodeficiency in our patients? This was already mentioned, because in several cases we have the ability to use targeted treatment options. For instance, for the overactivation of the PI3 kinase delta pathway, there is leniolisib that can be used as a specific inhibition and reduce the immunological complication with the disease without using general immunosuppression. For some diseases, there is enough experience now to indicate what is the specific immunosuppressant that works better. For instance, for deficiency in ADA2, anti-TNF therapy is the treatment of choice. And we know that thanks to the collective experience. We already talked about JAK1 and JAK2 inhibitors. Of course, if you know that the disease is a genetic alteration, overactivation of the pathway, you feel better in stepping to that class of immunosuppressant without perhaps waiting for the lack of response to other immunosuppressants. In the case where you can discover that the patient has a humoral immunodeficiency and is already on immunoglobulin replacement, also there you would probably step to the treatment with rituximab and or plasma cell depletion without waiting too long. There are, as Frederick mentioned, drugs specific to reduce the overactivation or the dysregulations of missed the word now, but to reduce the effect of CTLA-4 haploinsufficiency, LRBA deficiency, or DEF6 deficiency. So those are clearly information critical for the treatment that you want to have. For ALPS, we know that sirolimus and MMF are the drug that works, in better. And it's important, of course, to know that you're dealing with a disease that there is a combined immune deficiency where T and B cells are affected, because that opens the way to the discussion to possible indication of for hematopoietic stem cell transplant. So definitely there is a lot of advantage for the patients to be able to identify a monogenetic cause of their disease. For our patient, what would that have done? Certainly, it would have avoided the splenectomy. Splenectomy is not performed in patients with Wiskott-Aldrich syndrome unless there is an emergency. But an elective splenectomy, like these patients was subjected to, is a risk of a lethal infections, fulminant sepsis, and therefore he has risked death for 30 years of his life, and knowledge of his underlying genetic disorders would have avoided that risk. And I'm stopped there, and I will have answered to any question you might have.
Thank you very much. Are there questions? Perhaps one question from my side. For us, it's always a little bit strange to hear that we have immunodeficiency and then we should start immunosuppressive treatment. Can you shortly comment on this, especially in the context of immune modulation or something like this, not immunosuppression and targeted therapies?
Right. So it's definitely not a balance where there is an overactivation immune system and an immunodeficiency. There are, of course, an intersection of issues, and therefore the immunosuppression, immunomodulation that needs to be given is acceptable, and there are examples of many disorders where it is necessary and is done. In situations where the immune modulation or the immune suppression can be counteracted with immunoglobulin replacement therapy, for instance, those are easy situations. In others, the follow-up of the patients is more careful, and of course the potential of infections like pneumonias in patients on JAK inhibitors sometimes obligate you to step back and rethink the approach.
Yes, I think so too. It's really, we sometimes need very complex treatment regimens, and therefore this should be done in centers with the expertise in this field. Thank you very much.
So we move now from adult onset immunodeficiency to children onset immunodeficiencies, and it is an absolute pleasure to introduce Maaike Kusters, consultant pediatric immunologist from the Great Ormond Street Hospital here in London, who will give an overview of pediatric immunodeficiencies, please.
Okay. Yeah, thank you for this kind invitation. I'm a pure immunologist. I'm definitely not a rheumatologist, so I hope I can do this talk justice. But what I think is quite interesting is that we often, in the pediatric world, get patients with like hyperinflammation. And is it a MAS? Is it a HLH? Who's going to treat? Who's going to admit this patient? Is it hematology, immunology, rheumatology? Yeah, so that's basically the talk. So I'm also the ESET treasurer, and I'm also an associate professor. So basically, you could say, is it not all just the same? It's just a bit more sort of the same coin, but just, different sides. But actually, it's quite relevant to know if you are looking at a primary HLH, a secondary HLH, or a MAS. MAS, you know everything about it. It's probably bread and butter for you. But for me, the familial HLH is more the standard that I'm looking at. And these type of children, they have underlying conditions. Some of them are well described. Some of them come with other clues, such as albinism, EBV. EBV is such a cunning virus that can drive a normal host or an abnormal host into HLH or even towards lymphoma. So EBV is something of interest to always test. The onset of age, if you have a really young child, this could be a massive clue that the first presentation might actually be a primary immunodeficiency. But even in older children or in adults, first presentation, HLH can still be a primary immunodeficiency. The treatment is very different. So we can all start steroids, like every doctor can start steroids. That's not like super intelligent. And then you can add in something else. You can add in, HLH protocol, it's more cellular approach, etoposide, or you can go more with anakinra and just see how it goes. But actually, you also need to know, do I need to do further investigations before I drop down the immunology? Do I need to do genetics? And does this child need a bone marrow transplant? Because if we do, we need to move fast. So the main sort of thing is basically same fire, different fuel. So the mechanism, more like IL-18 cytokine kind of storm versus CXCL9, I think that becomes more sort of like a marker that is going to be used in the future in the different centers than just ferritin and your classic HLH criteria. In most cases, not always true, in mass and secondary HLH, you have like intact granular release assays, but sometimes they can be transiently reduced, and sometimes you also have hypomorphic variants that can actually reduce your cytotoxicity and then contribute to more susceptibility to a mass. But in my primary HLH, well, not if you have a perforin deficiency, because then your perforin is not released, but in all the other cases, you should have an impaired granule killing, and that's a defining defect, which requires really that HLH-directed therapy, including etoposide. And that's normally where people start to shake a little bit. Am I going to add in the etoposide? And then normally hematology or immunology are called. So the biomarker toolkit has moved a bit from just ferritin to actually soluble CD25, which has been used, I think, in a lot of centers already, towards also adding in CXCL9, sometimes also interferon gamma, and IL-18. And if you use that at the starting point, sometimes you don't get those results immediately back, and you need to act immediately if you think HLH. But still, you can use it over time, and in retrospect, you sort of know you're right or not, and you can also use it while you're starting a treatment to monitor, because if you have a more IL-18 ratio in comparison to the CXCL9, then you're more moving sort of mass steroids, anakinra, let's do methylpred pulses, whereas if you have the CXCL9, this is really an interferon gamma surrogate, and that sort of suggests I need a cellular approach, I need some cytotoxic approach, which basically includes etoposide. You can also use it, which I will show in some of these cases, as a sort of steroid and etoposide sparing approach. So this is a boy. I chose Grasselli because people might not know, but Claude Grasselli was a very important person in our field, and unfortunately he recently passed away, so I think I should put a Grasselli case in. So this is a 4-year-old boy. He had prolonged fever, hepatosplenomegaly, falling counts. He had a previous episode of ADEM, so a neurological sort of little wave, which is actually already a suggestion of some inflammation. It was said it was ADEM, but maybe it wasn't ADEM, maybe it was actually a presentation of a sort of light neuro-HLH neuroinflammation. This was actually already a massive clue, and that's why it's so important to go back to the history, and even if that history doesn't feel immunology or rheumatology, and neurology is actually really important in a lot of HLH underlying conditions, especially in Grasselli. So initially, sort of, let's give some steroids. Every doctor can start steroids. Initially, good response, but then a relapse. If you look closely to this child, the child did have black hair, but had some silver streaks in the hair. If you send those to a histopathologist who knows a bit about hair, a couple of hairs can basically define normal hair, celiac Higashi, or Grasselli. It's just the hair, comes back way quicker than your genetics. So in the right hands, you can already diagnose Grasselli based on a couple of hairs. In combination with a high ferritin and a high CXCL9, this is not a MAS protocol, this is a HLH protocol. abnormal hair, this kind of presentation, that's primary HLH, likely a Griscelli, which you also can define actually between celiac and Griscelli on the hair. And indeed, when we did the genetics, this was a confirmed REP27A mutation by allelic, and he was treated as HLH and moved quickly to transplant. You don't have to switch off the HLH completely because we can use a bit of the chemo in transplant to switch it off more, but it's best to have the HLH controlled and move immediately towards transplant in these type of cases. Absent albinism is not an exclusion for Griscelli, because more and more we find mutations across the globe that actually don't have the albinism and were initially not seen as, pathogenic mutations, but actually are. So this will become more and more prevalent over the years when more and more people are moving towards genetics, and it doesn't mean that the HLH is less severe. Some of these cases also present as lymphoma because they're very sensitive also for EBV, so, and also the isolated neuro-HLH with no ferritin, with no systemic features, can be definitely HLH and comes with a very high mortality. So because people miss it, because, look, there's no ferritin, but actually while the brain is frying and no one is treating or only too light and not thinking about an underlying immunodeficiency, the brain can have irreversible damage. So it's very important before you give any form of steroids, methylpred, dex, I don't care actually which steroids you would like to give, please take some samples. Even 10 mils of blood can make a difference for a workup before you dampen down the granular release assay. So this other case is a little boy, he's only 14 days old, which is already highly suspicious for a primary immunodeficiency, I would argue. He had fever, a rash, respiratory distress. He was treated initially as sepsis, but he was actually really unwell. He had a lot of ascites, hepatosplenomegaly, especially splenomegaly can be a massive clue for HLH. Ferritin was high, 20,000, and he had some cytopenias, and also some transaminases were elevated, which can also be an incredible clue for HLH. He went on the ventilator, couldn't actually find any bug whatsoever, but then when we did the functional assays, the granular release assay was impaired. Sepsiop in boys we also measured, this was all normal. Initially actually treated as a sort of a mass with dexamethasone, a bit of IVIG, anakinra, and then he really switched off in 4 days. So everyone seemed to be happy. But then when we started to wean the dexamethasone and the anakinra, he basically bounced back so quickly, even before the markers actually came up. So the ferritin didn't go up, and sometimes the ferritin is also delayed in coming up. This is really a bedside art where you have to look at the child sometimes multiple times per day as a consultant, and he had already the hepatosplenomegaly that disappeared, reappearing. This was a massive clue. And later, when we had more accumulative biomarkers such as CXCL9, soluble CD25, those were way higher than his actual ferritin. So we did a full protocol with etoposide and dexamethasone. But then in babies, what you normally see a lot is that etoposide is quite intense on the skin. So he had a massive breakdown of his nappy area. It was really completely broken down. The child was in severe pain and it was all bleeding and it was quite a disaster. This is the etoposide. So because we had these other markers, CXCL9 and the other markers, we could actually say, let's do a bit of imapalumab. Let's play a little bit with this HLH protocol. Maybe we can at least space the etoposide a bit. Let's add in cyclosporin and then see how he goes. And this actually got him to transplant, and he's actually now at home. So we're really happy with that because his underlying mutation was a homozygous STXBP2, which is not just HLH, it also comes with enteropathy. So this is quite a high risk, this is like sort of like 50-50 kind of survival if you have a baby in your hands who's this unwell. Again, before you kick in the etoposide, think tissue typing, think transplant. The moment my lymphocytes or my cells are out, I can't really tissue type and find a quick donor for bone marrow transplantation. So even if you save some cells and then give the etoposide, that already makes a huge difference. And please, send those markers, the granular release, etc., before you kick in any form of steroids. So what's a clue? When is it too much to be must? What's a red flag for my primary HLH? In the very young, especially if the first major illness, if there's no apparent trigger, Could be that there's infection, but it doesn't have to be, or there's no clear rheumatological clues in your physical examination. If there's, of course, consanguinity, or there's an affected sibling, or an unexplained infant death, which normally doesn't show up in your first history taking. You'd have to repeat it a couple of times, because people are just very stressed when their baby is that unwell. And it's only when they have asked their mom about their family history that you get more clues. Albinism, if it's present, that's beautiful. Scent hair, you can diagnose sometimes within 24 hours and you're like the hero of the day. EBV, really test it, because if it's high, and especially in boys, think XLP, SEP-SIAP, and you can test that already before the genetics in our immunology lab. And then if there's like refractory, you're trying to control it, but it's actually hard to control, then you're like, maybe this is not MOS, maybe this is a bit more. Then you also have to think HLH. And also if there's really severe involvement of neurology or isolated neurology, do a brain MRI, do an Doppler puncture, think about could this be actually a brain HLH, isolated or as part of systemic. The targets are very interesting. So the standard targets are dexamethasone, etoposide, sort of like let's knock it out of the park, and then cyclosporin is slightly later to avoid the press. But more and more you will see that we are playing with other types of immunomodulation, such as JAK inhibitor, which in this picture looks like it only has an effect on the macrophage, but it's not true. Of course, it has a really broad spectrum effect. And imapalumab, which is a beautiful, sitting there at the interferon gamma. You can also work with the Paris-Necker protocol with Campat. The Campat is a really hard, gun for HLH, and you really have to have this donor sort of setup to move to transplant after that, because you really flatten the immune system. But it works really beautifully, especially if you have neuro-HLH. And those are the kind of things you can play with the different targets if you know what you're doing, and also if you have those biomarkers, you can really see which target you need to. For any patient, it's about stabilization, and steroids is the sort of backbone of any of those protocols. And then treat the trigger and make sure that you're not having like a fungal or viral bacterial infection while you're suppressing the immune system. Then you look a little bit like, is this more IL-18? Is it more primary HLH? Then you go either MAS protocol or HLH protocol. And then you can also use those other markers to use sort of steroid sparing or etoposide sparing approaches, for instance, imapalumab or ruxolitinib, which can reduce those cytotoxic exposure. But do not hesitate. Like, if you think HLH, time is life, time is brain. Not taking a decision is also a decision. We're not talking about, am I going to buy a car? You have a child who has potentially HLH, and if you don't switch it off, the child will die. So you have to go fast with dexamethasone and etoposide as the backbone of HLH protocols, and then later you can make it more fancy and create your own recipe by adding in other ingredients. And always, I would say, this goes for anything in medicine. Use your BBB, your own brains, the brains of your buddies, and books, and I think now more and more also AI. So the take to work message, I should say. Call your immunology friends early. If you think, is this too much, or you feel like I'm not like feeling just the standard MAS, just call us, please call us, especially if the child is young, if there's consanguinity, if there's no clear rheumatological disease, if there's something shiny on the hair, gray, blonde, silver, if there's some EBV-driven disease, if it's recurrent or refractory to your standard treatment and you're not winning with steroids and anakinra, if there's neurological involvement that outweighs the systemic inflammation. But please take already a sample before you put the DEXA or the methylpred in. We need it for granulase or peripheral or SEP-SIAP in boys, sample for tissue typing and genetics, because this will make all the difference for the outcome of the child if there is an underlying primary immunodeficiency. We can do a lot with not a lot of blood. We can do a lot with only a couple of hairs, and we can do a rapid genetic panel. So basically, treat the storm, but ask yourself the question, what lit it? And in a child, and this is different than in adults, it really can be a first presentation of inborn errors of immunity, and it is really at a higher rate than in adults, where it's far more like malignant or autoinflammation that could be driving a HLH or a MAS. If it's too much, then genetics, call immunology, take those bloods before you pulse. And primary HLH needs a transplant for the child to survive. Okay, thank you.
Thank you so much for a very clear and detailed overview. So I would have loved to ask you a couple of questions. I particularly love the way that you gave the examples of the biomarker-driven approach, which for many of us in rheumatology is still like a holy grail. But we've been signed by the room teams that we need to close. So I'm afraid we need to move the question to the coffee break. Okay. So I'll ask my co-chair to close this.
So I'm asked to close the session. I want to do this by really thanking our speakers. This has been excellent talks. Thank you very much for coming here and teaching us on complex cases of immunodeficiency. And we all saw that there's great overlap to our field, and we will have to deal with secondary immunodeficiencies, and this will be the task for the future. Thank you very much for coming.